Hello, everyone. Today we are talking about pelvis and thigh disorders. These are Word documents. Well, actually, they're scanned in, so they're pictures. Just adjust that here. That you can print or, of course, read right off your D2L. So we're going to get started with the share screen. And we're going to go right into total hip replacement. So if you go to your D2L, it's going to be pelvis and thigh disorders. Again, like I said, these were scanned in, so it's not really a Word document. It's more like a picture. The first thing we're going to talk about today is total hip replacement. As I mentioned, you are probably going to see quite a few clients with hip replacements. Sometimes they'll be partial, sometimes they'll be total hip replacements. As far as massage is concerned, it doesn't really matter which one it is. So we're just going to talk about the total hip replacement. So in a total hip replacement, the acetabulum, remember, that's the little vinegar cup, is replaced with a plastic or plastic-ish socket, and then the head of the femur is replaced by a metal ball and a shaft. And sometimes there's a Teflon coating around that. So what it looks like is this. Okay, so you have a metal or plastic acetabulum. You have a plastic liner, or again, sometimes it's Teflon. And then you have a fake or metal femoral head, neck, and then shaft. And what happens really, I'm going to show you this, is that this metal shaft is inserted into the femur. So as you can see, the neck and the head of the femur were cut off, and then the metal piece is actually hammered, it's pretty brutal, into the shaft of the femur. And then, of course, the acetabulum is shaved down. Any of the degeneration is actually taken out, and then this piece is fitted to the acetabulum. And that's what it looks like on an X-ray then. So here's another one. And you can see this one with the screws in it. And of course, those are screwed right into the bone. And this is, of course, a coxal bone. This one actually fits very nicely. They try to size it right to you, and they make sure that it fits together really well before they sew you up. Okay, so again, all of the top of the femur has been taken off. But if you'll notice here, and this is kind of important, even though the head and the neck of the femur are missing, the greater trochanter and the lesser trochanter are still there because they are sites of a lot of muscle attachment. So you can't take those off because you have muscles that attach there, muscles that you need to walk. So that's still there and that's still there. All right, so what causes you to need a total hip replacement? There are lots of different things, but the most common is osteoarthritis. Osteoarthritis is the most common type of arthritis. It is the kind that is just wear and tear. Most people have some form of osteoarthritis by the time they're 40, in their hands or in their knees or something like that. Rheumatoid arthritis, fractures, necrosis, I'll talk about that later. All of those things can lead to needing a total hip replacement. So the symptoms of this are pain, and more pain, really, because as it progresses, it becomes more and more painful. And what ends up happening is, instead of that cartilage being in the acetabulum and on the head of the femur, you end up wearing away that cartilage. It becomes inflamed and sticky, and then ultimately what you end up having is bone on bone. Which is no good. I mean, you do have nerve endings there, and it is quite uncomfortable. So eventually you can't walk because it's too painful. Sometimes the joint itself actually starts sticking together, and then that limits range of motion. So those are the symptoms in general, is pain, and then signs would be not being able to walk up steps. All right, so for us as massage therapists, what do we do about this? Well, we're not going to see somebody just after their surgery. We need to wait about 6 to 8 weeks before we start working in this area. Now, as far as post-surgical massage is concerned, there's a couple of different categories. Post-surgical could mean like right after the surgery, where you're doing things like trying to move fluid out of the area because there's excessive swelling. Then there's post-surgical, which is 6 to 8 weeks out, which is what we would really do, where we are working on an area that has healed. The scar tissue has started to form in there. The wound itself is closed. And then we're not really going to work on that area. We're going to work around that area, okay? And then there's post-surgical, that's like 3 months out from the surgery, where all of the scar tissue, it has set for the most part, and we can actually start to work on that area, very gently help to make a more mobile scar so that nothing gets bound up internally. But that kind of thing might require an additional education because we don't teach scar tissue massage in this program. So things that you do need to be aware of: you cannot flex their hip past 90 degrees. You cannot adduct their hip past neutral, and you cannot medially rotate the hip. So what I recommend is that you just don't do any range of motion with the client. Now, if you were going to put somebody on their side, that's a little different, but you still have to avoid hip flexion past 90, adduction past neutral, and medial hip rotation. So when you are turning your client over onto their stomach, when you want to work on their back, then you have to do things like put a pillow between their knees in order to turn, because remember, they can't do adduction past neutral or any kind of medial hip rotation, okay? You just don't want that hip to dislocate. That would be very bad. So avoiding any kind of excessive motion of the hip is really what we're going for, okay? And again, we're not going to work on that area. We're going to work around the area that has had the surgery, okay? Later on, after it has healed entirely, then we can start working on some of the hip flexor muscles, the gluteals, you know, those muscles that would have been affected by the surgery, because they have a tendency to tighten up or become hypertonic after the surgery. However, the person that has undergone this hip replacement is going to have to do physical therapy. That is not an option. They are going to have to do physical therapy because it's difficult to walk after a hip replacement because all of those muscles have been affected. So you are most likely going to see them after they've been discharged from physical therapy. So their hip flexors and piriformis and gluteal muscles may not be super tight because of their previous therapy. But it would be something to check nonetheless, okay? So again, a couple of things to keep in mind. You absolutely must know these precautions because it's very important that you don't accidentally dislocate their hip. And depending on when it is that you start working with them after surgery, you're still going to need to do precautions like putting a pillow between their knees as you turn them over. Later on, maybe you can start working with hip flexor and gluteal muscles in that area, okay? But for the most part, you're going to work around the area, not on it. The massage is really just going to be tailored towards getting oxygen and nutrients to that area to help it heal. You're not working on the surgery site, okay? Moving on, so we have SI dysfunction. So that's sacroiliac joint dysfunction. This can happen for a number of reasons, but basically what happens is the pelvis rotates, and I'm just going to bring up the hip bones here for 1 second. So the pelvis is going to rotate usually anteriorly on one side. Okay, so instead of them holding tight to the sacrum like they normally would, one of them starts rotating anteriorly. That's the most common, or sometimes posteriorly. Okay, and that puts a lot of pressure on the ligaments that are holding that joint together. So it is most common in females, and especially during pregnancy when all of the ligaments in that area start to relax. And that's necessary in order for the pelvis to spread, for the baby to be birthed through the birth canal. So there are other times, though, that this can occur. One, during a woman's menstrual cycle, because hormones can actually cause some ligament laxity during that time. And that makes the SI joint more vulnerable. Also, poor core facilitation. Okay, what that really means is that your abs are weak. So if you have weak abs, excuse me, that can cause imbalance in the flexors and extensors around the hip, and actually, it can actually cause the muscles to pull the coxal bone into an anterior rotation or a posterior rotation. So the symptoms of this are going to be pain, but it's not just a little bit of pain. It's typically described, pardon me, as feeling like there's an ice pick in your glute. So right around the SI joint there. It says pain on one side, but that sort of understates it. Whenever somebody has SI joint dysfunction, it can be really, really painful. So you can help to rebalance the musculature in that area. But if the cause is ligament laxity, you are going to be able to help the muscles, but not necessarily the ligaments in that area if they're too loose. Do you know what I'm saying? So you can tell if this is occurring by looking at the ASIS or the PSIS. They will be uneven. So the PSIS is here on one side and maybe it's here on the other side. Or same with the ASIS, it's here on one side and maybe here on the other side. You will see a difference because there won't be a straight line between one and the other. Okay, one of them is going to look lower. Now, of course, massage is going to be indicated for muscular imbalance. However, you might have to take some precautions. This individual might not be able to lay flat on their stomach. You might have to put a rolled up towel underneath their hips as they're laying prone, okay? I have several SI joint discomfort clients or dysfunction clients who manage it through chiropractic, physical therapy, Tylenol, and massage. And I have to put a hip roll underneath every single one. So even though that's not on there, maybe mark that down somewhere just so that you know that you probably will have to do that. Okay. And again, SI joint dysfunction is more common in females than males. All right, so piriformis syndrome. I want to show you an image of the sciatic nerve. Well, this will bring up sciatica. I don't want that. This is what I want here. Okay, so for piriformis syndrome, basically what is happening, All right, basically what is happening is the piriformis is pushing on the sciatic nerve. So you can see the sciatic nerve here, how it runs the length of sort of the entire posterior coxal bone and then down the femur. It actually extends all the way down the back of the leg, where then it breaks up into a couple of different nerves. and then goes all the way to the bottom of the foot. So you know that the piriformis runs from the anterior sacrum. Let me get my sacrum out. It runs from the anterior sacrum to the greater trochanter of the femur. So it kind of runs across like this. And what happens is the piriformis gets really tight for whatever reason, maybe running, or maybe it's something that you did, or some way that you slept, or whatever, it doesn't matter. But if the piriformis is sitting here, the sciatic nerve is just posterior to it. So the piriformis is really tight, it can press on the sciatic nerve and cause pain and dysfunction. Numbness, tingling, it's going to go all the way down the buttock into the thigh. And symptoms are usually intensified by sitting. That's kind of one of the big keys of piriformis syndrome, is that sitting makes it worse, standing makes it better. So the treatment typically is going to be anti-inflammatory medications, muscle relaxers, stretching, and of course, massage. So we, as massage therapists, are going to be working on the piriformis through the gluteal muscles. So glute max, we're going to go down through glute max into the piriformis. It works really well, actually. Massage works very well for piriformis syndrome because it's muscular in nature. So if we can get piriformis to relax, then we can take the pressure off of the sciatic nerve, and voila! I actually had a client just last night with piriformis syndrome. He's a runner and he's training for a marathon, and he has stopped for the last week because he was having severe pain in the back of his leg when he was running. And from what he was describing, we were thinking that it was going to be hamstrings because they're in the back of the leg. But it turned out that what was really going on was a nerve pain caused by pressure from the piriformis. So in the session, I worked both sides because you must work both sides. Otherwise, you're going to leave the client unbalanced. And then what's the point, right? They came to see you for a muscular imbalance. The least you could do is balance them out, right? So we worked on his piriformis on the unaffected side. So the good side first. Any idea why I might do that? Yes, I do the unaffected side first so that I know what a normal side should feel like. So I have a baseline. So I did the unaffected side first, which he actually thought was pretty tender. And then I worked on the side that he described as being painful. And of course, there was a hypertonic piriformis. It was thicker, bigger, tighter on that side. And then when we were finished, he said that the pain had gone away. So that was wonderful. It only took really one session to work that out. And sometimes it works that fast and it's lovely. People think you're brilliant. Okay, so let's go back into these disorders. Now, this is picture one. So let's go to picture two, and we're going to talk about true sciatica. So piriformis syndrome is sometimes called pseudo sciatica because there we are, because it is pressing on the sciatic nerve and it's causing sciatic pain, but it is not true sciatica. True sciatica is compression of the spinal nerve root. So your spinal cord runs down posterior to the bodies of the vertebrae. And then you have these nerve roots that exit out either side. So you have the spinal cord and then you have nerve roots. And these nerve roots exit through the vertebral foramen and then they branch off and they become more, other nerves. Well, the sciatic nerve root starts all the way up in the lumbar spine. And a couple of different nerve roots actually come together to make the sciatic nerve, which is why the sciatic nerve is so big. But that's the key here, is that it is compression of spinal nerve roots. So what can cause compression of those spinal nerves? Well, herniated discs in the lumbar, like in between the lumbar vertebrae, bulging discs. So anything to do with the disc. If there's a disc issue, it can press on those exiting spinal nerves and cause pain. Something called spondylolisthesis, which is just a narrowing of the vertebral foramen. Degenerative disc disease. So you have this disc maintaining space between the vertebrae, but when it degenerates, there's less and less space, and therefore less and less space for the exiting spinal nerve roots. So those are the causes of true sciatica. Now, the symptoms are pretty much exactly the same as piriformis syndrome, because you've got pain, numbness, and tingling down the buttocks and back of the leg. It can even go as far as the foot, okay? It can cause muscular weakness in real severe cases. So the treatment, though, depends on the cause, whether it's a herniated or a bulging disc or degenerative disc disease. Typically, they're going to be on some kind of anti-inflammatory or pain medication. And they might also be on muscle relaxers, because sometimes when people are in a lot of pain, the muscles start to tense up in that area, kind of like to guard you from the pain. So outside of that, surgery, a laminectomy or a discectomy. Laminectomy we will talk about later. It is a surgical removal of the lamina, which is a piece in the vertebrae itself. Discectomy just means to remove the disc, because sometimes you need to. Pardon me. Now, as far as massage is concerned, if somebody is having true sciatica and the cause is a pinched or compressed nerve root, well, you as a massage therapist can't do anything about that, okay? But what you can do is work the surrounding muscles. So you can still work the glutes and the piriformis and the hamstrings, and you can still work the hip flexors and the quadriceps, and you can still work muscles in the back, but you cannot work directly over the lumbar area, okay? The problem is you don't have MRI vision. You cannot see exactly what is going on in the spine, and you cannot see exactly where that nerve root is being pinched. So if you are pressing in that area, if you're massaging in that area, you can make this worse, which you do not want to do, I know. So you can work around the area, but you cannot work in that area for true sciatica, okay? And I do find that my clients who do have true sciatica do get relief from me working the surrounding muscles, from working the glutes and the hamstrings and things like that. So just because you're not addressing the underlying issue doesn't mean that you can't help in some way, okay? And last but not least, we have avascular necrosis. And I need to show you what this looks like. No, thanks. Otherwise known as osteonecrosis. Images, let's show you some images. Okay. What I really want to show you, oh yeah, that's a bad one. Okay. Yeah, something like this is what I want to show you. Right there. Okay. Avascular. You have the prefix A on it, which means Without, correct. Vascular means blood supply, without blood vessels. So avascular means with lack of blood supply, and necrosis. So you have an osis here, which means a condition of, and necro means dead or death. So what this really means is that the blood supply to the head of the femur dies. It recedes for whatever reason. And that causes the bone here to die or become necrotic. So the head of the femur, the bone actually starts to die off. So here's a normal head of a femur. You can see blood supply, the holes are supposed to be there. It's healthy, it's robust. And over here, the whole head of the femur is dead. Okay, it has receded from the acetabulum. It starts to pit up at the top as it starts to get holes in it, basically. And then what ends up happening is the whole joint itself kind of collapses. No, not that one. Let me see if I can find a better one. Oh, there we go. Okay, so the whole joint itself starts to collapse. See that right there? Yeah. So the head of the femur starts to become pitted as it dies off. The joint itself starts to deteriorate because the head of the femur is deteriorated. And what ends up happening is you need a total hip replacement because this is no good. This doesn't work, essentially, okay? Now, avascular necrosis, oddly enough, is most common in the hip joint. And it really doesn't have a specific cause, but as far as causes in your notes are concerned, it says hip fracture or hip dislocation can spontaneously cause avascular necrosis because you can break a hip and it doesn't cause the hip to die. But avascular necrosis can be caused by dislocation or hip fracture. Rheumatoid arthritis, that's what RA stands for, and sickle cell anemia can also be causes. We haven't talked about sickle cell anemia yet, so we'll get there. Prolonged steroid use. Somebody who uses steroids all their life, and I don't mean like anabolic steroids, I mean even corticosteroids, things that you use like prednisone for inflammatory conditions, things like that. And again, prolonged steroid use, not just once in a while. Thrombus, so that's a blood clot. A blood clot can obviously block oxygen and nutrients to the head of the femur, so that can cause it to die. So those are the kinds of causes for avascular necrosis. Symptoms, of course, it's going to be painful, and it can radiate into the groin and down into the thigh. I find that people who have this beginning, they often talk about groin pain, and they can't pinpoint one specific area where it hurts. So sometimes it can be really difficult to diagnose. And then you can end up with a lack of range of motion because of it. Treatment, total hip replacement, like I said, that's THR there. Disease is most common in ages 30 to 50, which is kind of rough because you do not want a hip replacement before 50. Because hips don't last forever. They only have a 25 to 30 year lifespan. So after 30 years, you have to get another one. And typically they want you to wait as long as you possibly can before you get a hip replacement because they don't want to have to go in and do another one, especially when you're 80 years old. That's hard, okay? It's hard for your body to recover from something like that at 80. So the earlier you have a hip replacement, the more likely you are to have another one later on. So as far as massage is concerned, It's going to be regular Swedish massage. So you're not going to do any deep work. And of course, if they're saying that they're having pain in that area, you'll want to try to work in that area, but you can't go very deeply because you don't want to put any undue pressure on the bone there. So it's going to be kind of generalized massage in that area. You are going to increase circulation locally, which may or may not be of benefit because again, you don't really have MRI vision. You can't see how degenerated that bone is. And the person may not even know they have avascular necrosis when they come to see you with this type of pain. But if you know that they do, you're just going to do light massage over that area. And if they do, they're in line for a total hip replacement. So you know they're going to have surgery down the road a little bit or soon, depending on the state of the avascular necrosis. Okay, so I want you to actually take a look at these, I'm going to say Word documents again, I keep saying that, at the images on D2L. Make sure you read through them in their entirety after you watch the video, just so that it's fresh in your mind. There are some questions on the quiz about the disorders. So make sure that you've studied those before taking the quiz. And of course, if you have any questions on the disorders, you may post them in the discussion post, and I will try to answer them throughout the week, Monday through Friday. It's harder for me to get to that on the weekends. All right, everybody, have a great day.